Okay, now it should be working. I have given up on using Discord this time because it keeps on lagging. And the only way for me to not let it lag is if I reset everything, and I don't have the time to do that. Oops, that's not right. Let me know if you guys can see this. Let's see here. Excuse me. And I don't know if it's working or not. I'm gonna test. I'm gonna check something. It was good seeing Asha that one moment earlier, but she's acting very weird. Hey Asha, good to see ya. Good to see you, Asha. Sorry about that. Let's make a new one. All right. Let's see here. We only have a little bit of time today, but if anyone has any questions or any way that they want this to go, let me know. Let me know if you have a specific topic you want to go over today. Discuss about shock? Okay, that's no problem. We can definitely go over shock today. We have gone over it in the past, I think in the first YouTube live video, but no big issues here. So Asha wants to go over shock. No big deal. There's a couple different types of shock, right? Like we have hypovolemic shock, we have cardiogenic shock, we have what other shocks? Let me make sure I don't miss any of them. Different shocks. EMS. We have obstructive shock. We have distributive shock, which has its own specific category. So it's like sepsis. We have anaphylactic shock. And then we have neurogenic shock. And then you have to understand that there is a couple different types, right? So, there is compensated shock, stage 1. There is decompensated shock, stage 2. And then there is irreversible shock, stage 3. Okay, I need to borrow this too. Thank you. See if I have it pulled up here. So let's talk a little bit about the difference between compensated shock, decompensated shock, and irreversible shock. So for the most part here, if you have a patient going through shock, there's a couple different ways they could present, right? So early on in compensated shock, what can we expect to see? Let's say somebody's going through like hypovolemic shock. Their blood pressure initially may be like, let's say, 116/74. Their heart rate, because they're compensating, is probably at like 136, 140. Their SpO2 would be at like, let's say, 95%. Their respiratory rate is at 26 breaths per minute. Their temperature would be at 98.3 degrees Fahrenheit, and their finger stick would be at 108. So, if I asked you while you're looking at this, what are the abnormal vital signs out of all of these vital signs here, what would you say? Or what could you pick out? If I had to ask you, what vital signs seem alarming to you? The BP, the heart rate. Okay, we got a couple different answers. Hello, RDL man. The heart rate. I agree with the heart rate for sure. So, I wouldn't be concerned about the blood pressure. I wouldn't be concerned about the SpO2, the temperature, the blood sugar. But what would I be concerned about? I'd be concerned about the heart rate. Okay, so I'll put this in red. I'd be concerned about the respiratory rate. Why would I be concerned about these two? Because the heart rate normal range is between 60 to 100 beats per minute. The respiratory rate normal range is between 12 to 20 breaths per minute. And if I expanded on this, this would be beats per minute. Okay. So being able to recognize that is very important. That's why it's so important to master your vital signs. Okay. So what can we see here? We can see, like, let's say if somebody is going through, let's say someone's going through initial hypovolemic shock, right? Where they have, like, let's say some bruising or like a bleed. So what's the body trying to do? It's trying to work harder to perfuse to the rest of the body. So it's maintaining your current blood pressure, but how's it doing that? By beating faster for the heart, by breathing faster to try to make sure your SpO2 is fine. Your temperature, your blood sugar really shouldn't change that much at this stage. But that's what we're seeing right now, is somebody's going through compensated shock. Now, what does decompensated shock look like? Now we're seeing that their blood pressure is not being able to be maintained anymore. So what would we expect the blood pressure to look like? Let's say 70 on 40. Oh no, now the body's not able to maintain an adequate blood pressure. Their heart rate has gone from tachycardia, or above the normal range. Exactly, systolic below 90. Yeah, that's what we'd be expecting to see. The heart rate would maybe be at like 54 beats per minute. The heart has given up, it can't do anything. The SpO2 would be at, like, let's say 91%. Now their sats are starting to fail. Their respiratory rate would be at 8 breaths per minute. Their temperature would be at, doesn't really change much here, neither with the blood sugar, but maybe we can start to see that they have like a lower temperature, but we'll leave it at this. So now we have somebody going through decompensated shock, right? And let me check one thing. And so, taking my EMT-B Thursday, your videos really help. Well, I'm really glad to hear that, RDL. Good luck with your tests. That's fantastic. But now what can we see that's alarming? Because we reassessed our patient like 10 minutes into this hypovolemic shock call. Well, now their blood pressure is too low. Their SpO2 is too low. Their heart rate's too low. Their respiratory rate's too low. So now we have some more shocking vital signs. So, what do these vitals look like normally? Look like normally? Well, we would expect the blood pressure to be, I like to say 100 to 139 over less than 100. However, if you learn it as 90, like if you learn it this way, that's perfectly fine too. I think either one is a good way to look to learn it. Heart rate, I'd expect it to be 60 to 100 beats per minute. The SpO2, I'd expect it to be 95 to 100%. Some texts will teach you that a normal SpO2 is 95 to 99%. Some texts will teach you that 94 to 100% is normal. That's okay if your teacher teaches it to you that way, but honestly, it doesn't make sense to be worried about somebody at 100% SpO2. It's not like we're going to tell them to hold their breath, for instance. How many questions in the NRMT exam? Any ideas at passing score? Okay, I can answer that in a second. But respiratory rate, 12 to 20 breaths per minute. We expect the temperature, the way I like to teach it is 96.5 to 98.9. Although some texts will teach you that 96.8 to 100.4 is technically normal. That's okay if you learn it that way. The blood sugar, we're expecting it to be 70 to 110. Oh, I keep missing that. To 120 is considered normal. Some texts will teach you 70 to 110. If you learn it that way, that's okay too. Or 80 to 120, that's fine. You're asking how many questions? Many questions in the NREMT exam, and any ideas on the passing score? It's a great question. We're expecting anywhere between 70 to 120 questions, and the passing score should be at 950. So 950 and above is considered passing for the NREMT-B. Why they chose 950, I'm not really sure. And I can answer that in a second. Anyway, this is considered somebody in decompensated shock. Okay? And then irreversible shock, it's where the body's not able to maintain anymore, and they go from this state of perfusion all the way to like VFib, VTAC, without a pulse, asystole, or pulseless electrical activity. In decompensated shock, I just wanted to touch up on this real quick. What's a clear sign somebody went from compensated to decompensated shock? Let me actually clear this up. So I'm going to ask you guys this. What's a clear sign somebody went from compensated to decompensated shock? Where can we see like somebody that's like, oh yeah, they're in decompensated shock right now, their body's not perfusing anymore? What's like an obvious sign for that? Where we can say, okay, this guy is not doing good anymore. Blood pressure dumps, Wes, that's a good one. Frosty, Zosty, he says, or he or she says mental status, and Ashes is sweating. Frosty, Zosty, you nailed it. An altered mental status. When a patient has abnormal vital signs, yes, that's a very bad sign, Yakan. But we could say abnormal vital signs could be like our example for compensated shock, where we have an abnormal heart rate, where we have an abnormal respiratory rate. What's the clear sign that somebody has decompensated shock or is going that way? If they start from being ANO times 4, or alert and oriented, to person, place, time, and events, to an altered mental status. Okay? So very good, Frosty. Blood pressure, that's a good sign, yeah. But the clearest sign that you can visualize and see whenever you're assessing your patient is whenever their mental status changes. So imagine I'm talking to you and I'm able to answer all of your questions, and then all of a sudden I go unconscious, or I have like, I'm not able to respond to you properly. I have like a verbal, I'm only responding by looking at you when you talk, or only to painful stimuli. Well, then we can say, okay, this patient's going from compensated to decompensated shock. It's a very bad sign. And so, what are we looking for mental status? When we, yes, I can. I was about to actually do that right now because I know that's a tough point for a lot of people, Asha. When we assess someone's mental status, we think of two things, okay? We think of ANO times 4. Actually, really 3 things, right? And it depends on how complex you want to get. We think of ANO times 4. We think of AFPU. We think of a GCS score. Okay. ANO times 4 is alert and oriented times 4. What are some questions that we can ask a patient when we're assessing if they're ANO times 4? Or if they're alert and oriented times 4? What are some things we can ask if we're checking if a patient is ANO times 4? What's your name, right? So right there he has person. What's your name? What day is it? What time is it? Nice. Person, there's place, there's time. What day is it? And then Exactly. Where are you? Event. More so, what happened? Why were we called out, right? And then place. Who is the president? That's a great one to ask too. Usually it riles them up a little bit, but it gets their mental status going. Person, place. Where are you right now? Let's see. My mom had a patient yesterday. She's a caregiver. Yeah, our patient is like something years old, and I see agonal respirations and audible crackles. Feels like pneumonia, and they passed away. That is very unfortunate. Uh, Yakon, I'm sorry to hear that, but unfortunately, sometimes that just happens. Yeah, so what happened? Why would we call EMS? As a caregiver, I'm sure she knows how to tank that and deal with that, but I wish the best for your family member, your mother. Okay, but A&O times 4, right? We're asking these specific questions. What happens if I go up to you and I say, my name is Mario, I'm at my house, I don't know what day it is or month, and I called 911 because I have chest pain. Okay? What would you say? Would you say I'm A&O times 4? What would you kind of give me as far as for like my mental status if we're doing A&O times so forth? So what alert and oriented times is this patient? So Wes says A&O times 3. Anyone else? A&O times 3. So Yakan says A&O times 3. Exactly. And so he was able to say their name, where they're at, what happened, but they're not able to say what day it is. They're not unconscious because they're answering my questions. Dispatch the other for 61-year-old male showing signs of right-sided stroke, weakness, nonverbal agitated to pinpoint pupils, positive stroke test. Probably the other day for someone. That sounds tricky. Yolks? Okay, yolks. Like egg yolks. Okay, I'll call you yolks then. That makes it a lot easier for me. Thanks. That's interesting, Frosty. Sounds like a difficult patient. But strokes are usually, honestly, the easiest code 3 calls because all it is really taking them to CT and obtaining a good mental status, obtaining a good background information. Really, it just depends on you as a provider to how much questions you can ask on scene. Because you're the one who's being the point of contact for the ER staff. So it's really important you ask a lot of very intelligent questions. Yeah, and then getting a baseline on the patient, not just like a fast stroke assessment. You can do like a Cincinnati stroke assessment, but you want to really ask, what's their normal like? If we're talking about stroke patients, what, when were they last seen normal? Okay, we want to ask, do they normally walk and talk without issues? Do they use a walker? Have they had a stroke in the past? These are all really important questions to ask. And if you don't ask this and the ER staff talks to you and you can't give them answers to these kind of questions, you've really done a disservice to your patient. And then, of course, check a blood sugar. The pinpoint pupils threw me off. We were thinking we should have Narcan hit them. Yes, I agree you should have technically tried to Narcan them. Sometimes these stroke-like symptoms can actually be caused from a opioid overdose. And so we don't really think of elderly patients as patients who would be going through an opioid overdose. But you have to imagine there are scenarios where we have like elderly patients. They are like 81 years old, for instance, like or 61 years old, like your example. They have chronic history of lower back pain. And so maybe they take a tramadol, maybe they take a hydrocodone in the morning, and maybe they forgot and accidentally took 2 or mixed up their pills and accidentally took 2. That can put them in an opioid overdose. So you're good when you checked for pupils, but it definitely wouldn't hurt to administer Narcan to see if we can reverse some of the stroke-like symptoms. And maybe that's what was really going on this whole time. Blood sugar can also mask a lot of these symptoms. and it can make it seem like you have a stroke-like patient. As soon as you administer dextrose or glucagon or oral glucose, if they're ANO times 4 and have a patent airway, then we can potentially increase their mental status and reverse these stroke-like symptoms. But that's why it's really important to kind of like do your due diligence, check it. You're really good for checking pupils, but don't forget sometimes pinpoint pupils is technically something we can potentially reverse. Potentially, the pinpoint pupils can be from a couple things, but it was my LS write out. Finger stick was normal, so I was letting my medic. Yeah, no big deal, no big deal. But next time, I would highly recommend that you consider something like that. But good for you for assessing the pupils. I can be like a quarterback coach. What do they call them? Like I can point out all the pros and cons of everything you did, but it sounds like you have some really good assessment skills just by checking pupils. And it's just something to think about in the future. But I don't blame you for checking or not checking that, Frosty. Sounds like you did a good job either way. The Yoke says, not gonna lie, I always listen to the almost 2 hour long video review you have while you work as an Amazon delivery driver and just need to pass the NREMT and apply right away for EMT jobs. That's fantastic. Hey, maybe you can do both for a bit and really just start making money, right? But I think you're gonna like EMS, at least initially, Yoke. Because what's really great about it that a lot of people don't talk about, yeah, the hours are tough, but man, oops, I need a 2 again. Being able to work 24 hours at a time, and like let's say you work 48 hours or 2 days in a row straight, which is what I do at the fire department, getting all your hours in is so slick, and it is such an easy way to knock out like the hours that you need to like get your check for the week. It is really slick, and then you work overtime for a day, and then it's another 24 hours. You know, it can really add up really quickly if you have overtime opportunities. Yeah, I've done my EMT school and haven't passed my NREMTs yet. Don't worry about it, it happens. Oh, I'm also working Amazon 5 years and want to pass an exam to get a better job. Well, fantastic. Uh, don't worry about it. When I took the NREMT-B, I failed twice, then I passed on my third try. So I completely sympathize with you. That's why I kind of do some of the stuff that I do, because I like to think of it as if I was a student, how would I want to be taught to? And this is kind of how I would do. Taking NRMT in a few days. Any advice on how to study? Psh, what would I do? I would use amateurmedicine.com. That website is slick. Overtime can pay 1.5 times the original time. Sometimes, yeah. Yes, it definitely can. And then this has a really good test prep. I'd highly recommend it. Patient Q0. And yes, I've had it before where, man, I worked part-time at, don't worry about it, Yoke. I completely sympathize with that. No problem. Yeah, I try to give back. I find it to be pretty fun. And just past the basic, your YouTube video helped a ton. Congratulations, Josh. And Asha says, I passed my NHA exam CCMA, oh, like a medical assistant, but they're not paying good, so moving towards an EMS career. Well, really, your best bet is to get your EMT-B and then going straight for medic. That's my biggest recommendation. It can be very beneficial to go straight from EMT-B school to paramedic school. A lot of people say like, oh, spend a years in EMT-B, then after that, whenever you get good at it, or spend a couple years, then go for paramedic. That's a horrible idea. The first semester of paramedic school teaches you how to be a good EMT-B, and at the same time, you I would rather you have another year as a medic than another year as an EMT-B. You're used to taking tests whenever you go through EMT-B school, so that's really going to translate well than waiting a couple years and then taking paramedic or going into paramedic school. So I would highly recommend go for your EMT-B, then right afterwards go for your paramedic. That's my strongest recommendation, and I really think it's a good one. No, I wouldn't do that. No, I wouldn't go for my AEMT unless I had to. That's my recommendation. You spend almost the same amount of school going through AEMT school that you would in paramedic school. So I wouldn't recommend the AEMT unless you have no choice, unless your work is kind of like making you do that and they'll pay for it. I think that it's, I think there's some really talented AEMTs, and I work with some AEMTs, but if you can bypass this step altogether, I would bypass it. I think it's a really good idea. And I have a friend in SFFD. He works two jobs, firefighter and at the country fire department, and also an EMT. Oh, cool. Very cool. And I want to pass my NREMT exam and start my new job. Well, then you got to study, right? But I can try to help you with that. So, kind of going back in place, we went over ANO times 4, right? We knocked that one out. Can I mark it green? It's green. It's green. That means it's done. Next, we're going to talk about AVPU, okay? So let me kind of space this out a little bit. So, what does AVPU stand for? Do any of you know? What does AVPU stand for? And I'll give you a second to type it out. Exactly. Nice one, Yoke. You're right on track, West. There's just a couple more, but no big deal. So we have alert, verbal, painful, and unresponsive. Exactly. Hello, Amaya. Yes, you are absolutely right. And for alert, how can we check that? We can check to see if someone's ANO times 4. And then go on, hello, Dominique, good job. Yes. And then we can kind of work our way down, right, from ANO times 4 to ANO times 1. For verbal, do they look at you when you yell out to them? Right? So that's how I would generally assess for verbal. Do they open their eyes whenever you yell out their name? Do they open their eyes when you yell at them? Right? And then kind of have like a moderately stern voice, but don't be like screaming at them. But if that's not the case, do they respond when I do a sternal rub? Even though that's not really the best way to assess for painful response, it's kind of how I do it. You can also get like your pen and press a little bit against their fingernail, not too hard. And usually someone will respond that way. Do they pull away their arms when I inflict pain towards them? But a small amount, right? We're not trying to like hurt these patients. And then we have unresponsive. They don't respond to anything. Bad, right? So that's AVPU. It's alert, verbal, painful, and unresponsive. Okay? And this is how we go about assessing it. So that's another way that we can assess mental status. So we talked about ANO times 4. Then we went over alert, verbal, painful, unresponsive. AVPU, it's a very strong acronym. If you stink at assessing for a GCS, but you know what AVPU is, at least you can tell the ER staff while you're on the way. They only respond to verbal stimuli. They only respond to painful stimuli, or they're currently unresponsive. And then kind of build your skills towards a GCS. So we talked about AVPU. Last, we have GCS. Let's see here. Where is GCS? We're going to put it right here. And Mario, is it normal when, even though I was there yesterday at my mom's and helped switch the patient, the mom called me and told me that the patient passed? That is very sad. Yoke, I would be very careful talking about statements where, let me remove this. I deleted your message, Yoke. The only reason why I deleted it, be very careful with HIPAA, Yoke. I know you mean well, but I don't want you to say anything that specifies a specific instance for a patient, okay? So I would make things a little bit more discreet if you talk about it in the future. That's okay that you kind of brought it up this one instance, but I don't want you or anyone to get in any type of trouble by talking about past patients. Okay. So that's why I deleted that message. I just don't want you to have any issue. Don't worry about it. You're a student. You mean nothing from it, and you're just describing an instance. I just don't want you to have any issues like in the future. So just gonna kind of nip it right there. But yeah, it's normal to feel sad over an instance like that. But yeah, just be very careful with descriptions. Like we don't want to say like he, him, her for the patient. We don't want to describe when we saw the patient exactly, but you can say some things. Like you can say, I had a patient recently. Like if I were you, I would be like, I had a patient recently and they passed away. Is it normal to feel bad about this instance? And of course it is, right? Of course it is. We still are humans, even though we see scenarios that some people shouldn't have to see more than once. Um, and, you know, we were always going to feel a little bit bad depending on the case, especially for pediatric patients. But I would just be really careful about how you describe these kind of things. Something to think about. But let's go over GCS score. GCS scoring, right? And then this is one of my favorite images for GCS scores. I like this one a lot. And this is from Wiki SM, whatever that is. Oh, can I make this bigger? Expand. And this basically goes over how we assess for somebody's GCS score, right? So we check their eye response, their verbal response, and their motor response. We look at their pupils and we see if they open on their own, if they respond to speech, if they open whenever we check for verbal, for painful responsiveness, and no response. For verbal, we're assessing if they know their person, place, time, and event. If they're confused and so they kind of babble, they're like, if they talk to you and say, either like mumbled garbage, which would kind of be incomprehensible, inappropriate words, they're just spamming out random words, or they have like, they're confused and they'll be like, my name is Martin and I'm the president of the moon, right? Just confused nonsense. Then no response. We check for their painful or their motor response by seeing can they like lift their hands when I ask them to. If I start an IV, are they kind of moving towards it? Are they flexing away whenever I put a tourniquet on them? Do they have abnormal flexion, which means that they bring their arms inwards? Or do they have abnormal extension? They bring their arms outwards. Okay, and abnormal flexion can also be described as decorticate posturing. Abnormal extension can also be called decerebrate posturing. I think that's how you pronounce it. And what is it? It's whenever you inflict pain on them and they just bring their arms inwards, or you inflict pain on them and they stick their arms outwards. So we don't like either of those responses, but it's better than no response at all. And so if we look at the scoring, it goes between 4-1, 5-1, and 6-1. So that means for a GCS score, it can be between 3 to 15 for the score. 3 being completely unresponsive, 15 being completely responsive. So the higher the score, the better, usually for GCS, and it caps out at 15. For these type of patients, sometimes, like if you're a medic, they say less than 8 intubate. I do not like that thought process because you want to be really careful if somebody has like a gag reflex. But some paramedics will swear by like less than 8 intubate, and they may consider administering RSI protocols. But like for instance, you can have a GCS less than 8 and they're just drunk. And as long as they can protect their own airway and they're still breathing just fine, you know, just let them sleep it off. No need to intubate. So there's a couple of flaws with the less than 8 intubate thing, in my opinion. What would be a normal GCS? 15. A normal GCS would be a 15. 14 to 15. Sometimes we're not really that concerned. It may be something that's easily treatable. but 15 is fairly normal. Let's see. If we have an elderly female, if we have an elderly female patient who has a GCS of 14, they are confused, but everything else is appropriate. What do we expect? What do we consider as a possibility for their confusion? GCS means Glasgow score. I think that's how you pronounce it, right? Or how you say it? Oh, I messed up. Glasgow score. Glasgow Coma Scale. That's what GCS means. But if I have an elderly female patient, they have a GCS of 14, they're confused, but they're responding to everything else. What do we consider as a possibility for the confusion? So Yoke says hypoglycemia. It's a good one. What's something that's very common for elderly female patients in particular? Specifically, that group of patients. What could be causing their confusion? Dementia, yeah, dementia. Good to see you, General Not Steve. It's an option. What's a very big one for elderly female patients? And if you don't know, it's okay. Dementia, pharmacology, right? So maybe some of their medications or their RX could be causing it, Wes. But there's a very, very big one. And I'll give you some more hints. The patient is complaining of frequent urination, ammonia smelling urine, painful urination, and their urine is cloudy. Right, a UTI. That's kind of what I was getting at. A UTI, or a urinary tract infection. Exactly, General, exactly, Wes. Alzheimer's, yep, it's an option too. But the one I was really looking for is a UTI, a urinary tract infection. This is very common in female patients. A UTI is not. Oh, thanks for the extra idea, guys. Oh, yeah. Oh, it's okay, Yoke. Don't worry about it. That's why we're talking about it now. So we are potentially, whenever we have a female patient, we can ask some of their past medical history, like, oh, does she normally have like UTIs? And then usually they'll be like, yeah, she's had about 3 or 4 this year alone. Then we'll be like, okay, of course we're gonna do our due diligence. We're still gonna assess vital signs. We're still gonna get an EKG on this patient. But you know what? There's a good chance that they're probably just experiencing a UTI. It's not an STD. Unfortunately, with the female genitalia, it's very prone to infection. And sometimes, they might not be wiping as much as possible. Sometimes it's the detergent that they use. Sometimes it is the brand of underwear that they use. It may be more comfy, but it may leave them more susceptible to UTI. Again, it's not an STD. It's just something that's females are very prone to developing, especially as they become older. So it's just unfortunate. Males, how do they get it? Usually from males, it's unlikely that you're going to develop a UTI on your own. More than likely, it's if you sleep with a female and then you develop a UTI from them. So we want to treat both partners, of course. But for females, whenever they develop it, more than likely, it's not because of any type of like STIs or sexually transmitted infection. It's just something that their genitalia is prone to developing. So it's unfortunate. But as soon as I have an elderly female patient that has an altered mental status, that's one of the first things I'm going to. It's like a possible UTI. It's also like when you're preventing yourself to urinate. Exactly. So if they hold in the urine after an excess amount of time, you can develop a UTI. And how often do you go live and do this? I'm trying to do it 4 out of 6 days a week because I work for 2 days. It's not going to be possible every day, but every single YouTube live that I do, it also is going to pop up in like the channel, right? So if I go to here, where can I do this at? If I go here and then I go to YouTube, Actually, no. I won't pop that up. But there is a spot where you can kind of see the all the past live streams, and then I make it so that way the chat is part of the stream as well. But let's see here. But great question, Amaya. But yes, UTIs they can be caused from somebody who's holding in their urine too much, and a UTI, while initially not being too bad, but just kind of being irritating, it can become really dangerous later on because uh, for the study guide, yes, as far as for the test prep thing on amateurmedicine.com. But for this tutoring sessions, I mean, you don't have to pay for it. You can just jump in, right? It's all free. And then the study guide video, that's also free. So I give a lot of free resources too. But the issue with UTIs is they can travel up the urethra and then potentially infect the kidneys. And that's usually what happens if they don't treat their UTI for a couple weeks, a month or two. And that infected kidney can be life-threatening. It can be extremely dangerous. So we want to try to treat these patients whenever they have UTIs. I was using other EMT websites, but only have questions, no video explanations. Yeah, mine doesn't have video explanations. The one that I have, it really only gives you the type of questions that you need for the National Registry with some other resources. So I can link it here. But it's an option for you to utilize if you want to. But you can also always just ask me questions, and I'm more than happy to help. If you join the Discord, I'm more than happy to answer those questions as well. And then if you leave comments in videos, I try to answer them too. So you have a lot of resources, Asha, but it's something that I made. I could have made it more questions than what it is, but I think that that's just enough to help just about anyone pass the National Registry, which is why I developed it in that way. But what I wanted to do is I wanted to do a couple of practice questions. I thought it'd be a lot of fun. I always feel like knocking out these practice questions is a good way to kind of wrap things up. Let's see. Let's do some sample questions. Retake. So these are some questions that you can see. Are there live streams strictly for the NRMT exam? No. You can ask. That's a great question, General Natsif. You can ask any question you want, EMS related or really anything. Know that I'm also a firefighter too. I'm a fire instructor, fire officer, and a driver operator. So I have some pretty good fire knowledge too. But you can ask any question you want, General, and I'll just try to answer it to the best of my ability. You're using YouTube MSK CCMA exam, and first try I was passed with 85%. Good. If that works for you, then by all means utilize that. But let's see here. So I did want to go over some practice questions. We have here a question regarding the rule of nines, and this is something you can find on my website. If you just sign up, you don't even have to pay. You can do some of these sample questions and repeat them as much as you want. But we have a 6-year-old child that was burned in a house fire. They have burns to their entire back, their entire left leg, and their anterior surface of their right arm. What is the estimated total body surface area that's burned? It's a tough question. And what do we need to know if we deal with, let's see, rule of nines for a pediatric patient? Let me give you guys some back info real quick. Let's see. This is a really good one, but the only issue is that it doesn't go over the percentages right. Let's see here. So real quick, this is what I can do actually. This is more or less the rule of nines for a pediatric patient. Can I zoom out a little bit? Zoom out. Okay, where we have 13.5% for their legs, we have 1% for their perineum, for their genitalia, 9% for their arms, 18% for their head, and 9% for their chest and abdomen, 18% for their back. So just some back information. So Theoretically, if as an EMT-B, I have a patient who's complaining of nausea, is there anything I can do to help alleviate it? I know EMT-B, no. There's not really anything you can do. Uh, Hopefully you have like ALS intercept or something that you can do to request for Zofran. But honestly, I would just try to calm them down, have an emesis bag on the side, and transport them accordingly. AEMTs and paramedics can administer Zofran. You can't administer Zofran, unfortunately. But that's a great question, General. So Asha says 36%. Okay. So we have a pediatric patient. They have a burn to their entire back. So entire back is what percentage? It's 18%. What's the entire body surface area burn for their left leg? What's the burn surface area? Does anyone know for a pediatric patient? For a 6-year-old? What would be, using the rule of nines, their entire body surface area that's burned? Does anybody know? If not, it's okay. For your left leg, it's 13.5%. And then for their anterior surface of their right arm, what's the burn percentage? Okay, so if we're checking the front side of their right arm, what's their burn percentage? That's going to be not 18%, 4.5%, because you take 9 divided by 2. So if we add exactly. So if we add these up, we have 18 plus 13.5 plus 4.5. Is that the 3, right? Entire back, entire left leg, and the anterior surface of the right arm. What is that total? I can't pull out a calculator right now. Does anybody know what that totals out to? 18 plus 13.5 plus 4.5. So if we do, let's see, I can't pull out my calculator, but 14 plus 4, that would be 18 plus 18, that's 36. Okay, oh, good to see you, Blue. So good to see you. So we're saying 36%. We're saying 36%. Let's take a look here. And that's it. That is it, guys. For a pediatric patient, burn to their entire back is 18%. Their entire left leg is 13.5%. Their anterior right arm is 4.5%. And their total body surface area would be the 3 added up, equaling 36%. It is 36%. You're right, Asha. That's it. That is the total body surface area that's burned. It's a tough one. It's tough to get the rule of nines. The reason why I have a whole practice course included in my bundle that goes over the rule of nines GCS and the, what is this called? The APGAR score is because I know this section can be really tricky for people in general, or students in general. So, next question. You arrive on scene to find a 29-year-old female patient after an overdose. She does not open her eyes, makes incomprehensible sounds, and extends her arms when you apply painful stimuli. What's their GCS score? So, we're trying to calculate this patient's GCS score. They do not open their eyes. They make incomprehensible sounds, and she extends her arms when you apply painful stimuli. Okay, so abnormal extension. So what's their GCS score? So let me ask you guys this. If a patient doesn't open their eyes at all, what's the eye response from 1 to 4? The feminist says 5. We're going to see. Good to see you, the feminist. it's A, you say it's 5. Okay, we'll get into it. But I have you tallied for A. So if they don't open their eyes at all, it's 1, okay? And then you say incomprehensible sounds, you're saying 2, and then you're saying plus 4 because they have abnormal extension. Oops. Okay, so you say 5, you say A. Let's see what the score is. So we have 2 people that say 5. We have 1 that says 8. We have 1 that says 7. Let's see. We have more people are saying 5 than anything else. So we're going to see if that's it. And it is 5. And why is it 5? Let's look at the rationale. Their eye is opening, or the eye opening response is a 1. They have no response. Their verbal response, they have incomprehensible sounds. It's going to be a 2. And their motor response, they have abnormal extension. So RDL and the feminist, you got it. You nailed it. And how can we kind of look back at that? We can look back at... Oh, shoot, decorticate. It's okay. And actually, it would be decerebrate posturing with abnormal extension. So for that particular patient, can I make this red? And let's make it kind of bigger. We would see a patient that has no response to their eyes. They have incomprehensible sounds. So a 2. And abnormal extension. That's a 2. So we add them up. It's 1 plus 2 plus 2. That's a 5. Don't worry about it, Yakon. But just remember that decerebrate posturing is abnormal extension. And then abnormal flexion is decorticate posturing. Imagine somebody's bringing their arms to their core. That's how we can tell that it's abnormal flexion. But don't worry about it, Yoke. That's why we're practicing it now. So whenever it comes times for test time, you can be able to decipher it on your own. Let's see. Let's do another practice question. I need to respond to a text super quick. Yes. I just had to say yes real quick. But that's the rationale behind everything. Now we're going to do an APGAR score question. Ooh, everybody shudders. An APGAR score? What the heck? But let me pull up some imagery before we do an APGAR score. Let's go over it real quick, then we'll talk about it. APGAR scoring. This is a really good imagery right here. I'm just going to pull this, copy image. So before I pull up the image, when do we do an APGAR score? When do we assess for an APGAR? Does anyone know? When do we check? You're gonna say 0. The feminist, I know you're on top of your game, all right? We're gonna go over it a little bit with people, then we'll start to get the scoring, okay? When do we check an APGAR? Does anybody know? So we see first 5 minutes, then 10 minutes from Yoke. From Blue, we see birth and 5 minutes later. It's okay. I want some varied responses. Then we see first minute and 5 minutes. We see after birth from patient. The important thing is you're throwing out your guesses, right? I don't care if you guys get it right or wrong. Our DL man says 1 and 5 minutes. Any other guesses? But I'm going to give you guys the answer. We, first minute, then 5 minutes again from the feminist. Okay, so we check an APGAR in the first minute of birth and again at 5 minutes. That's when we assess an APGAR as far as EMS is related. Okay, we check it twice. And what are we looking for? We're looking for more so a positive trend. We're looking to see if the patient's APGAR score is improving, right? We want it to get better. So, what's the score for an APGAR? It goes from blank to blank. What's the highest score? What's the lowest score for an APGAR? What is the highest and lowest, or the lowest and highest score? for an APGAR. Okay, Yoke says 0 to 10. Anyone else? Zero to 2. We have 1 to 10. Ah, it's okay. Anyone else? Anyone else? We're going to go. It's okay. You're absolutely right in that regards, the feminist. I can see what you mean for like each category 0 to 2. I'm pretty sure you know what it is. You seem like you're pretty on top of it. But the scoring is going to go from 0 to 10. Don't worry about it, patient. That's why we're talking about it now. Okay? And you can see here that I pulled this up from browntrialfirm.com. But basically, we're going to have a score between 0 to 2 points. And so we have some different things here, or some different context. We have appearance, pulse, grimace, activity, and respiration. And I have a pretty good YouTube video that goes over all of this in pretty good detail. Because a lot of people struggle with the APGAR, but it's honestly not too hard once you kind of get used to it. And I'll explain the rationale on why I think it's pretty easy. So we have skin color. What is the best skin color? If they're pink everywhere, right? Ooh, can I undo this? It's way too thick. If they're pink everywhere, that's good. And we'll put green here. I guess it doesn't matter because I'm going to color all over this. But, of course, what would we expect to be normal skin color for a patient? Pink, right? When is it getting kind of bad? When their skin is pink, but their arms are blue. They have some type of like vasoconstriction going on, right? And then we have blue, pale skin. So it's either all blue, cyanotic, or all pale. What are we thinking? That their score is a 0. That it's bad, right? A pulse over 100 beats per minute is good. Generally, we want it like at close to 160 beats per minute. So 120 or 110 to 160 is pretty good. Below 100 beats per minute, that's bad. But they still have a pulse. So then what's the worst? When they don't have a pulse at all, right? Then they have prompt response, so they respond well, to minimal response, it's kind of bad, to it's very bad, they don't respond at all. Activity, it goes from moving around a lot to only flexing their arms and legs to no movement, right? For respiration, it goes from a vigorous cry to a slow, irregular cry to no crying at all or no breathing at all. So you can see a lot of the 0 scores are all the same, right? Where we have absent or the lack of a particular category. That's bad. Here, it's basically going to be like minimal or like lower than a certain amount for the 1 point. And then 2 is whenever we have some child that's actively moving, responding appropriately, that's a 2. Okay? So, if we go back to this practice question. And we see here, a newborn is cyanotic all over. They have a heart rate of 95 beats per minute. They show minimal flexion to their extremities. When stimulated, they grimace, but they don't cry. And her breathing is irregular and shallow. So they're still breathing, it's just irregular. What would you give this patient score for an APGAR? And I'll give you a moment to think about it. RDL says B, that it's a 4, right? So cyanotic, tactical EMT, how's it going? It's good, tactical, good to see a 4. Okay, so we see somebody else saying a 4, because we would say that this is a clear 0, right? This heart rate, 95 beats per minute, it's less than 100, but they still have a heart rate. It's a 1. Minimal response, that's a 1. When stimulated, they grimace, but they don't cry. Their breathing is irregular and shallow, so it's not a 2. It's like a 1. So we have some 4s here, some 4, 4, 4, 4. And so, overall, we're going to say that their score is we're all going with 4 here. You could do a cap refill on newborns as well. Yeah. Although I really wouldn't. I would more. You have so many different interventions that you're dealing with a child that's born. I would more so focus on the mother, focus on the baby, focus on getting your APGAR score, and then uh, go through your algorithms accordingly. And that's a big topic. Okay, and you guys all said 4. There you go. You did a great job on answering that question. That's the rationale behind it. So, fantastic job, everybody. You guys did great. Again, there's the whole rationale behind everything, how we add them all up, but you guys did a really good job. Um, Unfortunately, we're gonna kind of have to wrap things up really quick. I've got to pick up my daughter, and she has a volleyball game that's coming up. These videos, just like anything else, are going to be posted on YouTube. It is a knowledgeable video. Thank you. Oh, no problem, Asha. Uh, I'm just trying to help you guys be the best EMS providers that you can be. But if you have any, no problem, Yoke. Does anyone have any last minute questions? I'll leave it up to the floor. No problem, the feminist. But in a moment, I'm going to go ahead and end it. But you can find practice. Can you please next time? Okay. It's a very knowledgeable video. Thank you. Okay, Asha, thank you, the feminist. It's very nice of you. Prepare some best topics. Okay, sure, sure. Yeah. Prepare some best topics. What do you mean by that? Is there no problem, Yoke? Thank you very much for stopping by. What do you mean by prepare best topics? What do you mean by prepare best topics? Just so I can know to kind of prepare for that. Like shocks? Sure, sure. And then also, let me see if I can link it. I think there's a video that you'll like that goes really into shock. And I'm going to link it in here just for you. If I go to live, okay, I don't want you to be loud. Okay, this is the first live stream that we had. You should do a really confusing scenario. That's a great idea. I'm going to write that down. Let's see. That's a fun idea. I kind of like that a lot. But I linked a video in there, Asha. But basically, it's the first YouTube live stream that we did a couple days ago, at least in this bout. And it goes over shock completely. And I think it'll really answer a lot of your questions. Okay. So I would highly recommend clicking on that link and checking it out, Asha. I think it's going to answer a lot of your questions regarding shock. And it's labeled, the video over shock is on the channel in the live section, and it's labeled basically live EMS tutoring for free #1. Okay, it's the first one, and I think that'll answer a lot of your questions regarding shock. It's no problem at all, Asha. I know we kind of went over shock, but we really stopped at compensated, decompensated, and kind of barely touched up on irreversible shock. We definitely could have done a better job answering that. So sorry about that. If I had more time, I'd go back into it. But all right, I'm going to go ahead and be ending it. Thanks again for stopping by. Oh, Yoke, don't worry about it. If you pass, a lot of that is up to you because you sought that additional knowledge. So you don't have to thank me as much as you are, but that's nice of you. I finished my EMT class and study and know everything for your other long thing. You think it means I have a high chance of passing? Of course I do. Of course. And I recommend, Blaze, that you take the test right away. What's another resource you can utilize? There's always amateurmedicine.com. We have a study bundle that's like, I think it's like $20 a month. But it gives you practice courses on vital signs, on the NREMT exam, on the GCS EPGAR Rule of 9 section, and then it gives you a really slick 26-page PDF that you can download and print out. That's all filled out for you. Yes. Yes, sir, Yoke. What is it? I can link it again. Unupdated? I really need to, Yoke. Are you able to post an updated 2 hour long video review? Uh, I really need to because I messed up on the SpO2 range and the respiratory rate, which is kind of embarrassing. But it takes so long to do. It's very tricky. And then to do all that for just 2 mistakes whenever I can put it on there, I recommend it. It helped you pass EMT school. Oh, phenomenal, the feminist. That's so good to hear. Oh, the course, even more phenomenal, the feminist. I agree as well. It does help. How do I heart? How do I heart a message? Uh, I don't know, but I can throw hearts on myself. That's kind of funny, right? Do, 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 do. You can do all kinds of things. Whoa, that's a lot of fun. Okay, I'm getting too distracted and I gotta get ready to go. All right, well, I'll see you guys later, okay? See ya.